Welcome in, everybody. Ready for a deep dive.
Absolutely. Always ready to dig into some fascinating medical mysteries.
Today, it's all about congenital diaphragmatic hernia, CDH. Got some compelling journal articles and patient stories here.
Yeah, this one is a real eye-opener when it comes to, how complex prenatal development can be.
For sure. Okay, so for anyone just joining us, CDH is a birth defect. The diaphragm, the muscle that's like essential for breathing,
Right.
that doesn't fully form.
Right.
And because of that, some abdominal organs, they can actually migrate up into the chest cavity.
Exactly. So we're talking like intestines, the stomach, even part of the liver in some cases. They sort of push their way up.
And of course, that impacts lung development, right?
Huge impact. I mean, you've got these organs crowding the space where the lungs need to grow. So you end up with what we call pulmonary hypoplasia, essentially underdeveloped lungs.
So it's not just a simple case of things being in the wrong spot. It's like this domino effect.
Exactly. And it all starts before birth, so the baby is already facing an uphill battle.
And I imagine the severity can vary quite a bit.
Oh, absolutely. We see a whole spectrum. Some cases are so mild they might not even be detected until much later in life.
Mm-hmm.
But then you have cases that are immediately life-threatening at birth.
Okay, so let's get into the nitty-gritty here. What actually causes this to happen during fetal development?
Well, the diaphragm is supposed to form, in a very specific way.
Mm-hmm.
It's a pretty amazing process when you think about it. But with CDH, something disrupts that.
And do we know what that something is?
It's still an area of active research, but the thinking is that it's likely a combination of factors. There's probably a genetic component at play,
Right. Makes sense.
and then you layer on top of that potential environmental factor.
So it's not like, oh, the mother did this or that.
Right.
Which I imagine is a bit of a relief for parents.
Definitely. It's important for parents to understand this is a complex developmental issue, not something they necessarily did or didn't do.
So since CDH develops prenatally, is it something that can be detected before birth?
Most of the time, yes. Prenatal ultrasounds are our main tool for that. And thankfully, they've become pretty sophisticated. Often, CDH is picked up during those routine scans, which is a good thing because...
Gives the medical team time to prepare.
Exactly. But sometimes it's missed or develops later, so it's really crucial to be aware of the signs and symptoms in newborns.
What kind of signs should parents and medical professionals be looking out for?
Well, rapid breathing is a big one.
Okay, so just breathing way too fast.
Exactly. And then the baby's skin might have a bluish tint to it, which we call cyanosis. That's a sign that they're not getting enough oxygen.
And that's because the lungs aren't able to function properly.
Exactly. Another sign is what's called a scaphoid abdomen, meaning the belly looks kind of sunken in.
Interesting. I wouldn't have thought of that.
And then probably the most telling sign is if you listen to their chest and the breath sounds are really faint or missing on one side.
Makes sense. The organs are basically in the way of the airflow.
Right on.
So let's say a doctor suspects CDH. What's the next step to confirm the diagnosis?
A chest x-ray. That's the gold standard. It gives you a clear picture of where the organs are and the extent of the hernia.
So you have this newborn struggling to breathe, organs all over the place.
Yeah.
I'm guessing the go-to response used to be rush them into surgery and put everything back where it belongs.
You got it. That was the traditional thinking. Immediate surgical intervention, get those organs back where they're supposed to be, and hopefully everything will sort itself out.
Seems logical, right?
Yeah, on the surface, it seems like the obvious solution.
So what changed?
Well, despite these efforts, the mortality rate remained really high.
Like how high?
Like over 50% in many cases. So it was kind of a wake-up call. CDH was clearly more complicated than we initially thought.
It's almost like realizing you've been treating the symptom, not the cause.
Exactly. We had to start thinking differently about the whole problem.
So what was the big shift in thinking?
Well, the main thing was recognizing that those underdeveloped lungs, they'd been squished for so long, they couldn't just magically start working normally, even after surgery.
Right. They need time to recover.
Precisely. So the focus had to shift from immediate surgery to stabilizing the baby first.
Stabilizing them.
Meaning addressing those breathing problems right away. And often that includes managing pulmonary hypertension.
Pulmonary hypertension, that's high blood pressure in the lungs, right?
Exactly.
Right.
And it can be a very serious complication with CDH. So the idea became, let's create the best possible environment for those lungs to start working properly. Then we can think about surgery.
So it's about giving those lungs a fighting chance, basically.
You got it.
So what does that stabilization process actually involve?
Well, first off, it's all about gentle ventilation. We want to avoid putting any more stress on those fragile lungs.
Right, because traditional ventilation can sometimes be too aggressive.
Exactly. And then in the most severe cases, we might use something called ECMO.
ECMO, that's some serious stuff, isn't it?
It is. ECMO stands for extracorporeal membrane oxygenation.
Catchy name.
Right. But basically it acts as an external lung. It allows us to bypass the baby's lungs altogether, giving them time to rest and heal.
So the blood is circulated outside of the body, oxygenated, and then returned.
You got it. ECMO is a lifesaver. Literally, it buys us precious time.
But it's not a permanent solution, right? Eventually, a surgery is still needed to repair the diaphragm.
That's right. But the key is we're doing that surgery on a much more stable baby. The lungs have had a chance to recover, and the overall risks are lower.
Okay, so let's talk about the surgery itself. What's typically involved?
Well, the main goal is to close that hole in the diaphragm.
Seems straightforward enough.
Sometimes it is. But often, especially with larger defects, we'll need to use patches to reinforce the closure.
Patches? Like, what are they made of?
Lots of different materials.
Mm-hmm.
Some are synthetic, like Gore-Tex. Others are derived from biological tissue.
So like almost like a scaffolding to help rebuild that diaphragm.
That's a good way to think about it.
So, surgery is done, baby is stable. Are we in the clear at that point?
Well, survival is obviously the first victory.
Yeah.
And the improvement in survival rates with this new approach has been phenomenal.
Yeah.
But CDH can have long-term implications. It's not just a one-and-done kind of thing.
What kind of long-term challenges are we talking about?
Well, for some babies, they might develop chronic lung disease. Others might struggle with gastroesophageal reflux or GERD.
The dreaded GERD.
Right. And because of everything their little bodies have gone through, there's also a risk of developmental delays. Things like motor skills, language development, those sorts of things can be affected.
So even after they leave the hospital, the journey isn't really over.
Not at all. These children require close monitoring and often need a whole team of specialists involved in their care. Pulmonologists, gastroenterologists, developmental pediatricians, you name it.
It really highlights how complex CDH is.
Yeah, absolutely.
So before we move on to specific case studies, I'm curious, what stands out to you the most about CDH so far?
I think for me, it's that paradigm shift in treatment. Going from just focusing on surgery to really understanding the whole picture, the physiology of it all, that's been a game changer. And it really speaks to the dedication of the medical community to constantly learn and improve.
What about you? What struck you? For me, it's the fact that it all starts prenatally. It really underscores how critical those prenatal visits are.
Yeah, absolutely.
Those early ultrasounds can make a world of difference.
Now, are you ready to dive into some case examples? I think they'll really help bring these concepts to life.
I think our listeners would love that. Let's do it.
All right, so this first case, it really highlights a key difference between right-sided and left-sided CDH.
You mentioned earlier that most cases are on the left side.
Yeah, that's right.
And that those tend to have, like, better outcomes overall. Why is that?
Well, it comes down to the organs that are involved.
Okay.
Think about the liver, right? It's big, it's solid, yeah, really dense. So if the liver is the one that herniates up into the chest, it's going to put a lot more pressure on that developing lung.
So more compression, more damage, essentially.
Exactly.
So right-sided hernias, since the liver's on the right, those are just trickier right from the start.
They can be. They often require, more aggressive interventions. The risks are higher.
Makes sense. Okay, let's switch gears a bit. What about those surgical patches? We talked about them earlier. Are there any potential complications with those?
Well, one concern is always infection. Anytime you introduce a foreign material, even if it's sterile, you're increasing the risk.
Right, especially in a newborn.
Especially in a newborn, their immune systems aren't fully developed.
So infection is definitely a worry. What else?
Another thing we see sometimes is chest wall deformities.
Oh, interesting. How does that happen?
Well, as the child grows, the patch can actually restrict the movement of the ribs. So you might end up with things like pectus excavatum.
Which is where the chest looks caved in.
Yeah, exactly. Or scoliosis, which is a curvature of the spine.
So it can have, like, skeletal impacts long term.
It can, which is why it's so important to monitor these kids as they grow, make sure everything's developing as it should.
All right, let's talk about GE Ray for a minute. Gastroesophageal reflux.
Sure.
You mentioned it as a common issue for kids with CDH. How does that tie into the whole anatomical changes thing?
Well, think about where the stomach and esophagus are normally situated, right? With CDH, they get shifted upward into the chest,
Right.
and that can mess with the lower esophageal sphincter.
Which is the muscle that, like, keeps stomach acid down where it belongs.
Exactly. So it's like the whole system gets disrupted.
And then that acid comes back up, irritates the esophagus.
That's GERD in a nutshell. Painful, uncomfortable, and it can even damage the esophagus over time.
So on top of everything else, these poor kids have to deal with GERD. Are there any other, like, gastrointestinal problems that are common?
Yeah, sometimes scar tissue can form after surgery, and that can lead to bowel obstructions. And because the intestines weren't in the right place during development, there's an increased risk of something called volvulus.
Volvulus, that sounds scary.
It is. It's when the intestine twists upon itself. It's a surgical emergency.
So it's really clear now that surviving CDH is just the beginning.
Right, it's a journey.
It's a long road with a lot of potential bumps along the way. You mentioned earlier that survival rates have improved dramatically.
They have.
Can you give us some actual numbers? What are we looking at these days?
Well, at specialized centers, the ones that are really equipped to handle CDH, survival rates are now between 70 and 90%.
Wow, that's incredible. That's a huge improvement.
It is.
But I feel like there's a but coming.
Well, those numbers, those are the babies who make it to those specialized centers.
Right.
Unfortunately, some babies with CDH are still born, and others pass away before they can even be transported for treatment. So the overall survival rate is, sadly, it's still lower than those figures suggest.
It really highlights how important it is to have access to specialized care.
Absolutely. And that's why research is so important. People are working hard to find better ways to diagnose CDH prenatally and even to develop treatments that can be done in utero.
In utero treatments, that sounds like science fiction.
It does, doesn't it? But it's becoming more of a reality. They're doing some amazing things with minimally invasive techniques.
Like actually operating on the fetus while it's still in the womb.
Well, not open surgery as we typically think of it. It's more like using tiny instruments, guided by ultrasound, to try to correct the problem before birth.
It's mind-blowing to think about how far medical science has come.
It really is. Okay, so we've talked a lot about the physical challenges of CDH, but what about the long-term neurodevelopmental impact? We touched on it briefly before, but I think it deserves more attention.
Yeah, you mentioned things like motor skill delays, language delays. How often do those actually occur?
Well, unfortunately, neurodevelopmental impairment is seen in a significant percentage of CDH survivors.
Significant meaning?
Studies have reported rates anywhere from 30 to 80%.
Wow, that's a pretty wide range.
It is. And it just goes to show how complex this condition is. There's so many factors that can influence a child's development. The severity of the CDH, any complications during treatment, whether they were born prematurely, individual genetic factors, it's all part of the equation.
So it's really hard to predict how any one child will be affected in the long run.
It is. But what we do know is that early intervention is key.
Like the sooner you start therapies and interventions, the better.
Exactly. Things like physical therapy, speech therapy, occupational therapy, those can make a huge difference in helping these kids reach their full potential.
It's all about being proactive,
Yeah.
not waiting to see what happens.
And it's important to be aware that hearing loss is another potential complication, particularly for those who needed ECMO.
ECMO again. Lifesaver, but not without its risks.
Right. It's a powerful tool, but it can have consequences.
So let's say a baby is finally ready to go home from the hospital. What does post-discharge care look like for a CDH survivor?
Well, it's all about ongoing monitoring and support. The American Academy of Pediatrics actually has some great guidelines for follow-up care.
What kind of things do they recommend?
Oh, it's a whole range of stuff. Regular checkups to track their growth, chest x-rays if they had a patch put in, pulmonary function tests to see how their lungs are doing, hearing evaluations, developmental screenings, nutritional assessments, you name it.
It really does take a village to care for these kids.
It does. The goal is to catch any potential problems early on and get them the help they need.
This has been an amazing deep dive. I feel like we've really peeled back the layers on CDH.
Me too. It's a fascinating condition, and it's incredible to see how much progress has been made in treating it.
But clearly, there's still a lot more to learn and discover.
Well, absolutely. Before we wrap up, is there anything else that you think is important to highlight?
I think it's really important to emphasize that while CDH is serious, it's not a hopeless situation.
Yeah.
There is hope. There are amazing resources out there, support networks, incredible medical advancements. And knowledge is power. The more you understand about CDH, the better prepared you'll be to face it head on.
That's a great point, and I think it's a perfect segue to our final thought for the listeners to chew on. We've talked a lot about surgical patches,
Right.
but these are kids. They're growing constantly. So how do you deal with a patch that might become too small as the child grows?
Yeah, that's a really good question. I mean, kids grow so fast, especially in those first few years.
It's a huge challenge. Surgeons are constantly trying to come up with better solutions.
So what are they doing? Like, what's the current thinking on how to address this?
One approach is to use patches that are designed to expand as the child grows.
Oh, wow. So like a self-adjusting patch? That would be incredible.
It will be a game changer. But, those materials are still pretty experimental. There are still a lot of questions about how durable they are, whether they can really stand up to the wear and tear of a growing child.
So those aren't really widely available yet. What happens if a child has a traditional patch and it does become too small
Well, in some cases, they might need a second surgery.
to replace the patch?
Yeah, either replace it with a larger one, or in some cases, they might even be able to reconstruct the diaphragm using the child's own tissue.
I imagine that's a much more complicated surgery than the initial one.
It can be.
Hmm.
And of course, any surgery carries risks.
But sometimes it's necessary.
It is. You have to weigh the benefits against the risks. And each case is different. You have to consider the individual child, what's best for them, and obviously the family's preferences play a role too.
It's a big decision.
It is.
So it sounds like there's still a lot of room for improvement when it comes to treating CDH, especially this whole issue with the patches.
Absolutely. And that's why research is so important. There are some brilliant people out there working on this problem, trying to develop new materials, new techniques that will hopefully make a difference for these kids.
Well, that's encouraging.
It is. CDH is a tough condition, but we're learning more about it all the time. And the more we learn, the better equipped we are to help these children and their families.
Well said. Any final thoughts before we wrap up this deep dive?
Just this, if you or someone you know is facing a CDH diagnosis, don't lose hope. There's a lot of support out there, incredible medical advancements, and as I said before, knowledge is power. The more you understand about CDH, the better you'll be able to advocate for yourself or your loved one.
That's a great message to end on. Thanks so much for sharing your expertise with us today.
My pleasure. Always happy to talk about this important topic.
And to all our listeners out there, thanks for joining us on this deep dive into CDH. We hope you learned something new and that you feel empowered to keep learning and asking questions. Until next time, stay curious.